Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. We invite you to sign up for our newsletter to stay connected to all future programs.
All right, I think we'll go ahead and get started. So welcome everyone to today's program, Frankly Speaking About Cancer. This program is specific to bone health. I'm Katie Armsby with Cancer Support Community Atlanta. And for those of you who are new to Cancer Support Community Atlanta program, we welcome you and invite you to visit our website, cscatlanta.org. There you can see a complete list of the programs that are available. We offer some really great nutrition seminars, stress reduction classes like yoga and Tai Chi. And then we offer, of course, education programs like these. And then I do want to highlight our support groups that are available. And again, that bone health series, that exercise series that's starting next month. So of course, we invite you to join us for any of these programs, and you can register and find out more on that website, cscatlanta.org. And I have to interrupt myself. We have someone who is joining us from Orlando and then New Jersey. So I think New Jersey, you win the prize, which today is going to be you can register for our exercise class. But thank you for joining us. It's so great to see people from all over. All right, so again, I'm going to promote our website, cscatlanta.org, where you can see a complete list of everything that's available. I'm excited to introduce today's program moderator, Dr. Sandra Chang. Dr. Sandra Chang earned her medical degree from Tufts University School of Medicine, completed her residency at the University of Illinois, and pursued a fellowship at Emory University. Drawn to oncology for its complexity and potential to profoundly impact lives, Dr. Chang emphasizes patient-centered care, blending clinical expertise with empathy and a deep respect for each person's goals. Dr. Chang practices with Suburban Hematology Oncology Associates in their Duluth clinic. And with that, I'm going to pass it off to you, Dr. Chang, to get us started.
All right, thank you so much, everyone, for joining us today. We have a great turnout here. It's my pleasure to introduce the program facilitator, Dr. Sreedevi Avdhani. She's one of the endocrinologists. She received her medical degree from Sri Siddhartha Medical College in Tumkur, India, and completed an internship at New York Hospital in Pennsylvania. She went on to complete a fellowship in endocrinology at the University of Mississippi in Jackson. She's double board certified in internal medicine and endocrinology. And she's also a member of the American Association of Clinical Endocrinologists, the Endocrine Society, and the American College of Physicians. Her clinical interests focus on endocrine health and related disorders. She practices at Northside Hospital Diagnostic Clinic in Duluth, which is right across the street from Suburban Hematology Oncology. Okay, welcome.
Thank you, Dr. Chang and Katie, for introducing me, and thank you, Cancer Community Atlanta. This is a very important topic, and when they brought this topic to me, I jumped at it. And today my presentation is all about bone health and what affects bone, what is osteoporosis, and what can people with osteoporosis do to keep their bones strong and as healthy as possible. So what do we mean by bone health? I'm going to jump right into the presentation. Like your muscles, your bones are living, growing tissues, but they just happen to be hard. Bone is made up of mostly protein, collagen, and some minerals, calcium, phosphorus. It has two layers. You have an outer layer, which is the cortex, and an inner layer, which is called the trabecula. The cortex is the harder part of the bone, and it's the most dense part of the bone. The trabecular bone is the spongy structure of the bone. Now, our bones basically protect our organs, our brain, heart, and other organs, supports the body, gives us the skeletal structure, stores minerals like calcium, phosphorus, and keeps them strong. And it also makes red blood cells, white blood cells, platelets in a place called red bone marrow. And it also stores and releases fat inside a yellow bone marrow. So that is in the hollow core of your bones. Now, I'm going to talk about bone remodeling. So your bone is constantly changing. This occurs by two processes. There's something called as bone resorption. Our bone has two specialized cells. One is called osteoclasts. Osteoclasts are the one that break down and remove old bone tissue. And we have osteoblasts, which are these blue cells that come in and lay down new bone. So these generally occur in sync with each other. As the osteoclasts are removing dead bone, the osteoblasts are coming in and placing new bone. So this is a normal, healthy bone remodeling that occurs. Now, bone density changes over your lifetime. When you're younger, your bone builds more bone tissue than it breaks. So your osteoblasts are working faster than your osteoclasts. So the more bone tissue you have, the larger and the denser your bone is. If you look at this graph, most of us, our bone density improves as we age, and the peak is around 30. After the age of 30, our bone starts becoming less dense, and we start losing bone faster than we are building. So that is seen after the age of 30 when our osteoclasts, which are the bone removing cells, are working faster than our bone building cells. And these changes can happen in women who have decreased estrogen, contributing to bone loss. I'm sorry, I think I clicked something here. In women and men with low hormones, or men and women who have calcium and vitamin deficiency. And exercise can actually help slow down this bone decrease in the bone density. Smoking, alcohol consumption can speed up the osteoclastic function, since causing increase in bone turnover or remove the bone density faster. Now, how do we check the bone density? There is a test called as DEXA scan, otherwise called as dual X-ray energy X-ray absorptiometry. And this is a low dose X-ray scan, and it measures the amount of minerals like calcium and phosphorus in your bone. And typically we measure the lumbar bone, or that is the spine, and the hip and the femur. And when do we do? According to the guidelines, we generally, as a preventive, we test women at the age of 65, and men if they have secondary problems which cause increased bone loss around the age of 70, but can be done sooner if you have certain problems or certain medical conditions. Now, the scan results generally are reported as a T-score. Now, T-score is a measure of how your bone density is compared and what you would expect to see in a young person who is at the same sex as you. So a T-score of -1 or higher is a normal or a good bone density scan result. Any T-score between -1 and between -2.5 is called low bone mass or osteopenia. And T-score above -2.5, I mean lower than -2.5, is called osteoporosis. Now, what is osteoporosis? Osteoporosis is a medical condition where women and men have bones that are quite thin and weak and can easily break. So osteo in Greek means bone, and porous is basically the porous part of the bone. So if you look at this picture, the left bone looks like a normal bone, and the right bone is the osteoporotic bone with more pores or more porous. So it is a silent disease. You will not know until you break a bone. So your bones get weaker and weaker, and you easily break a bone. So that is what osteoporosis does, is fragility fracture. That's what we call a fall from a standing height causing a fracture in either your lumbar spine, your hip, or your femur, or the distal forearm or humerus. Any of these fractures are considered as an osteoporotic fracture. Now, looking at this slide, the one on the left is a normal bone. So you see less pores or less spaces, which is a normal bone. And the one on the right looks like more spaces. It looks like a honeycomb, but more spaces. So it's less dense and easy to break. So when you fall, you break a bone easily. Now, how common is osteoporosis? Now, according to the current estimates, about 54 million people in the US have osteoporosis and osteopenia combined. Of that, 10 million alone have osteoporosis, the remaining 44 million have osteopenia. And about 2 million bone fractures are just because of osteoporosis. So you can see how busy the orthopedic surgeons are at this point. Now, how do I define a osteoporotic fracture? As I said earlier, any fall from a standing height, we call it as fragility fracture, and fracture of a hip, your vertebra, the backbones, humerus, which is the bone of your upper arm, the distal forearm bones, they're all characterized as a major osteoporotic fracture. So the estimate right now is 1 in 2 women and 1 in 4 men will break a bone from osteoporosis in their lifetime. So who is at most risk of osteoporosis? So there are, we know that women who are in menopause, age about 60, high risk. Men age around about 60 at high risk. If you have a strong family history with a parent with osteoporosis, you are at a higher risk. And women after menopause, because of decreased estrogen, they are at higher risk. Now, for both men and women, estrogen is needed to keep their bones strong. In men, testosterone gets converted to estrogen in their fat cells. So that's how we keep our bones strong in men as well. Now, there are certain conditions or diseases that can accelerate the loss of bone or bone density, causing osteoporosis. Diabetes is one of those diseases, and certain diabetes medications can actually accelerate bone loss. Kidney and liver disease, patients with chronic kidney disease, chronic liver disease, they have accelerated bone loss. Certain types of cancers can cause bone loss, that is, cancers that are spreading to the bone, or cancer treatment alone can cause bone loss. And certain eating disorders, patients who have anorexia nervosa, where they are extremely thin, a BMI of less than normal, can cause significant bone loss because of decreased calcium, vitamin D, and decreased mineral intake. And patients with gastric bypass surgery who are not able to absorb enough calcium, vitamin D, can have significant bone loss. And then you also have certain endocrine disorders like hypoparathyroidism, parathyroid gland, which is a gland that sits right behind the thyroid gland. It controls the calcium in our body. So any surgery or any radiation to the neck or any head and neck surgeries that cause the removal of parathyroid glands can cause low calcium. And that's how your bones start losing all its calcium. Overactive thyroid, hyperthyroidism is one of the reasons for osteoporosis. So I have seen patients who have been treated with levothyroxine and want to keep it at a more suppressed TSH, which is called hyperthyroidism, can actually accelerate their bone loss. So we always want to keep their thyroid levels at a normal range. Now, there are certain medications, as I said, cancer medications, certain diabetes medications, and then heartburn. Acid reflux medications can actually cause bone loss because of decrease in the acidity of the stomach, and that decreases the amount of calcium we can absorb. And steroid is a very big medication that actually causes bone loss. So patients are on steroids for other rheumatological issues, rheumatoid arthritis. They're on steroids for asthma, COPD. They're on steroids for cancer treatment. That can increase bone loss. Certain HIV medications can cause bone loss. Certain blood thinners like unfractionated heparin can cause bone loss. And as I said, thyroid hormone, which is taken in a higher dose than normal, can cause bone loss. Now, some cancer patients are being treated for osteoporosis at the time of their diagnosis, or they are receiving cancer treatment that may increase the risk of developing osteoporosis and can potentially further they reduce their bone density, or they have certain cancers that have started in their bones, can decrease their bone density, or they have spread to the bones, which is called metastasis to their bones. So we're going to talk about more cancer treatments that can affect bones. So the cancer treatments which are generally used in women for breast cancer, which is a medication that causes premature menopause. So certain young women who have breast cancer and they are getting medications like aromatase inhibitors, or they're getting certain medications to decrease the amount of estrogen in their body, can cause decrease in their bone density. So there are postmenopausal women who are receiving aromatase inhibitors like anastrozole, letrozole, and certain men with prostate cancer who are receiving Lupron. It can cause decrease in their testosterone levels, in turn causing loss in their bone density and osteoporosis. Now, chemotherapy can cause a loss in the bone density. Radiation itself can actually cause the imbalance in the osteoblast and osteoclast activity in the bone, causing bone loss. Now, even transplant, allogenic stem cell transplant or bone marrow transplant patients, they're higher risk of having bone loss. Even childhood cancer survivors who have received high-dose steroids as a young patient, or who have not been able to have good dietary intake as they are growing into their adulthood, their bone density is not as great at the age of 30 as a normal adult would have. They are at an increased risk of osteoporosis. So any surgical treatment, as I said, any gastric bypass surgery or gastrectomy can actually cause decrease in absorption of your calcium and minerals and cause increase in bone loss. Now, if you're being treated for osteoporosis, please talk to your oncologist or hematology doctor, radiation oncology doctor, and the surgeons that you're being treated for osteoporosis or have been diagnosed with osteoporosis. Please also talk to your doctor who is treating, the endocrinologist or rheumatology doctor who is treating you for osteoporosis. Know that you have been diagnosed with cancer, because there are certain treatments that we use for osteoporosis and cannot be given in patients who have a certain type of cancers. So it's a two-way thing. I would suggest talking to both the doctors and taking care of your health. So whenever patients come to my clinic, I always ask them, please write down all your medications that you're taking. Keep them with you in your bag or your purse, or carry with you all the time. I have patients who come in with me and I have no clue what is going on. And some of my oncology doctors don't know that I'm treating patients for osteoporosis. So I think the patients have to write down their drugs, the dose, the treatments that they're doing, and carry with them, keep it up to date. Now, certain chemotherapy drugs can actually cause low calcium levels and cause hypocalcemia. And this is a temporary effect of some chemotherapy drugs. Certain head and neck surgeries, as I told you, can result in low calcium level. I already explained to you about the parathyroid gland. So removal of parathyroid gland. So parathyroid gland, when I explain to the patient, it is a gland which is right behind the thyroid gland. So para means behind. And all it does is it controls calcium and phosphorus in the blood. So it tries to maintain calcium phosphorus homeostasis. And most of us have 4 glands, which are the size of a rice grain. And some of us have a 5th gland anywhere in our body. And all these 4 glands, they work in sync. They basically are trying to keep our calcium and phosphorus normal. Now, sometimes what happens is one of these glands is hyperfunctioning or underfunctioning, or it has happened that patients who had surgery of their thyroid gland, the surgeon inadvertently removed the parathyroid glands, causing hypocalcemia. this can cause hypoparathyroidism, that is decrease in parathyroid hormone, causing decrease in calcium levels, and in turn causing osteoporosis. Now, chemotherapy drugs that can affect hormone production in women. Some chemotherapy drugs may cause the ovaries to stop functioning, and this will change a woman's hormone level and put her at immediate risk of menopause and put her at increased risk of osteoporosis. In men, some chemotherapy drugs may cause the testicles to stop functioning, and this can cause their testosterone levels to drop. So both of these can cause bone loss. Now, as I told you, radiation, it weakens the bone and cause osteoporosis by damaging the osteoblasts and osteoclasts, the cells that actually are building and removing the dead bone. So this in turn causes loss in bone density. This is concern for many patients, particularly men and women who are receiving radiation to their brain, spine, hip, and leg. In these patients, we have to keep a close eye on their bone density and check with bone density or DEXA scan. Now, many of the hormone therapies that are used to treat breast cancer reduce estrogen production. This is a repeat slide. In premenopausal women, the breast cancer hormone treatment, tamoxifen, it actually increases the risk of osteoporosis. However, if this drug is used in postmenopausal women, it actually increases their bone density. This is called as a selective estrogen modulator. So it selectively increases the bone density, however, decreases risk of breast cancer. So this is one of the drugs that I always ask our oncologists if we can try in postmenopausal women. Now, men being treated for prostate cancer who have decreased testosterone production, because their treatment includes androgen deprivation or decrease in the testosterone levels, or they've had their testicles removed, which is called orchiectomy. Also puts them at increased risk of osteoporosis. Now, whenever men come to my clinic for low testosterone levels, called as hypogonadism, I always tell them that testosterone feeds the prostate. So testosterone causes your prostate to enlarge. And when you have a prostate cancer, testosterone is completely contraindicated in these patients. At that point, they are treating you with medications that will decrease your testosterone production to a extremely low level and putting you at a high risk of osteopenia, osteoporosis. Now, certain steroids most of the steroids that we take actually causes bone loss. Patients, women and men who are being treated with corticosteroids, either dexamethasone, prednisone, and taking more than 5 milligrams a day for more than 2 months are at increased risk of osteoporosis. Cancer patients whose treatment include prednisone, prednisolone, dexamethasone are at increased risk. And then certain patients with COPD, certain lung conditions, certain rheumatological conditions who are on high-dose steroids, they are at increased risk for osteoporosis. So it's always good to let your rheumatology doctor know, your primary doctor know that you're on steroid, and they are going to monitor your bone density closely, or taper your steroid to keep you on the lowest dose possible. Now, coming to treatment of osteoporosis, there's a lot of new drugs that are in the market. I generally explain to the patient that there are two kinds of treatment. One is called anti-resorptive medication. So the way we are treating patients is either slow down the bone removal, which is the osteoclastic cells, or help with bone formation, that is the osteoblast. So the first drug class is called anti-resorptive medications. The way they work is we are decreasing the amount of osteoclasts, or we are trying to remove the osteoclasts from the cells. So that's how it gave more time for the osteoblasts, that are the bone building cells, to build your bone up. So one of these drugs is called bisphosphonates. It's a class of drugs, and there are several drugs in this class. Fosamax, most of the patients are on Fosamax. Its generic name is called alendronate. It comes in 70 milligram pill, and take it once a week. I generally tell patients, please take this medication half an hour before eating your food. and with a big glass of water and no lying down for 30 minutes. The reason being it has side effects of acid reflux, can cause nausea, abdominal pain, heartburn. Generally, these drugs are given, oral medications are given for 3 to 5 years. Resedronate is another medication which is marketed as Actonel, comes at 35 milligram once a week. And then I'm sure everybody heard of Boniva, Abandronate, which comes at 150 milligram monthly pill. All these are oral pills, and Boniva also comes in an injection form. Now, these drugs are quite cheap and covered by most of the insurances. Now, zoledronic acid is an IV form of bisphosphonate called as Reclast, and we give it once a year in the infusion center, 5 milligram yearly. Now, how do we decide how long to put these patients on either Fosamax or oral medications versus IV medications? When I see patients and I talk to them, we get a history from patients. Generally, the first question I ask them is, do you have acid reflux? Patients with acid reflux, I generally avoid giving them Fosamax or Actonel or Boniva because of the risk of heartburn or worsening heartburn. The other thing is I tell them, hey, if you are taking omeprazole, then I would suggest taking this medication half an hour before you eat and with a big glass of water, and don't lie down, because lying down will worsen the acid reflux. Now, the oral medications, generally, I ask patients to take it for at least 5 years, 3 to 5 years, because of non-compliance and forgetfulness. Taking it once a week, you need to remember, you need to take the medication. So I tell them, we will give it a trial for up to 5 years. But in the meantime, always do bone density every 2 years to see if there is any improvement. The IV Reclast is generally given once it is done. You have it, you don't have to take another one for a year. Both the IV form, I generally give it for 3 years and then monitor to see if the bone density has improved. If it has improved, I talk about drug holiday. Drug holiday is if there is an improvement or there is low risk of fracture, we generally give it for 2 to 3 years, no medication for 2 to 3 years, but with monitoring of bone density. Now, the IV Reclast, immediate side effect after the IV infusion, they generally given in the infusion center or 15 minutes, and they monitor you for any immediate allergic reactions. But within first 3 days, we generally tell patients may have muscle aches and pains, fever, headache, flu-like symptoms. I'd tell patients take Tylenol as needed and hydrate with plenty of fluids. Now, there is a rare side effect seen on bisphosphonates. Patients ask me these questions all the time. It is atypical fracture and osteonecrosis of jaw. Now, atypical fracture is a fracture on the upper 1/3 of your femur, thigh bone. And generally, it is a crack in your bone. So you've not completely fractured. Patients come in saying, I have pain in my groin or in the mid thigh, upper thigh. And I generally get an X-ray to see, and if there is a crack, they get intramedullary nailing, or I send them to the orthopedic surgeons, and they have to either get a nailing done, that is the screws and a intramedullary open reduction internal fixation of this crack. The other thing is, in these patients, I switch them from bisphosphonates to a drug called as anabolic medication to build your bone, which I'm going to talk in the next slides. Now, osteonecrosis of jaw, this is a very common question most of my patients ask. This may occur when your tooth is being pulled while on treatment with bisphosphonates, but I have not seen patients who are taking either Fosamax or Reclast just for treatment of osteoporosis with osteonecrosis of jaw. I have seen it in patients who have been treated with cancer and getting Reclast or one of these medications more often than yearly, or getting a higher dose. In these patients is more common than a normal patient for treating osteoporosis. I generally tell them good dental hygiene is very important. Magic mouthwash will help most of the time, but always follow up with the dentist and make sure that there is nothing going on. The other drugs in this class, the anti-resorptive medication, raloxifene, which is sold as Evista, comes as 60 milligram pill taken every day, mostly for women and postmenopausal women. It's used to reduce breast cancer, which is a selective estrogen modulator, and it helps to treat osteoporosis. Now, it has shown some improvement in decreasing vertebral fractures, but there is no improvement in non-vertebral fractures. That is your hip, your humerus, or your distal forearm. It does cause side effects like hot flashes, increasing blood clots, because it is an estrogen, selective estrogen medication. Now, testosterone has not been studied to help treat osteoporosis. However, to elevate the symptoms, we generally give patients testosterone, but along with testosterone, we also give some form of a osteoporotic medication, either a anti-resorptive like bisphosphonate or denosumab Prolia, which I'm going to talk in the next slide. Now, as I told you, testosterone I do not suggest in patients with prostate cancer because it feeds the prostate. Now, Prolia is another drug which is called as denosumab, which is a monoclonal antibody, comes in 60 milligram shot. You get it once every 6 months in your stomach, and it is approved for postmenopausal women, men who have osteoporosis or any osteoporosis because of steroid intake or cancer-induced osteoporosis and bone loss. Now, the difference between Prolia and the bisphosphonate is that in Fosamax, in reclass, you can give a drug holiday because they tend to bind to the bone stronger than Prolia. Prolia, the way it acts is it irreversibly binds to the osteoclasts, which are the bone resorption cells. And after 6 months, by 7th month, if you don't get a shot every 6 months, I tell the patients, please make sure you're getting a shot every 6 months. Do not delay it for more than a month. Studies have shown that if you delay it after a 7th month, there's increased risk of vertebral fractures, more in T12, that is the thoracic 12th vertebra. And you also have some fractures in lumbar, even without a fall. So there is high risk of vertebral fractures called as rebound-associated vertebral fractures because of not taking your Prolia on time. Now, we don't talk about drug holiday in Prolia. However, the old talk was once you're on Prolia, you're on it for life. However, that has changed. The new guidelines say that we try to give Prolia in patients for at least 5 to 7 years to build their bone to the maximum. And once we have built either vertebra or the hip to a certain max or to an osteopenia range with a low FRAX score. So low bone mineral density, which is osteopenia, we sometimes calculate a FRAX score, which is to see how likely is the person can fracture their bone in the next 10 years. Now, if the FRAX score is high, I generally label them as osteoporosis. Osteopenia patient with low FRAX score is we wait and watch. In those patients, if the Prolia improves their bone from osteoporosis to osteopenia with a normal FRAX score, we generally transition those patients after 5 to 7 years to another medication, either initially with Fosamax, because what I've seen is once we stop Prolia, you start losing the bone faster than you have built. So in order to stop that, we put them on Fosamax or alendronate or Boniva within 4 or 5 months of stopping Prolia. Give that for a year. After a year, I transition them to IV reclassed once a year for 1 year or 2 years, and then give them a drug holiday. In that way, I prevent the risk of vertebral fractures and also help restore or keep the bone strong. Now, the other class of medications that I was talking about, other than the anti-resorptive medication, is the anabolic agents, which basically stimulate new bone formation. Now, under these, there are 2 classes of drugs. One is the parathyroid, human parathyroid, synthetic form of human parathyroid hormone. There are 2 drugs in this class, which is teriparatide, sold as Forteo, and abaloparatide. Now, both these medications are given as daily shot in your belly, subcutaneous shot in the belly, and we ideally give it for 2 years. There are studies now ongoing to see if we can give these drugs for a longer duration than 2 years. And at this point, anabolic agents are one and done. So once in a lifetime, and then no more, no longer repeat. However, there are newer studies that are showing that it is promising and can be given for longer duration. The treatment generally is for 2 years with either Forteo or teriparatide. Patients can take it at home. Teriparatide needs to be refrigerated. Valoparatide need not be refrigerated, so it's a nice drug to carry when you're traveling. Now, the reason we use these drugs are if somebody has failed either Fosamax, reclassed, or Prolia, or have a fracture on these while being on these drugs, then these are approved. Or a very severe osteoporosis with a T-score of below negative 3.0, or in a patient who has had immediate fracture or fracture healing, we generally transition them to one of these medications. Now, it has shown to decrease vertebral fracture by 65% and non-vertebral, that is your hip, your femur, by 53%. Now, the side effect of these medications are like any medication, the site of injection, allergic reaction. It can also cause nausea, can cause low blood pressure, hypotension, leg cramps. Because it's a parathyroid analog, I talked about parathyroid hormone, it will increase your calcium levels. So I would suggest drawing blood 16 hours after the last shot. So if a patient took their shot around 12 noon, they are good to get their blood drawn next morning, 8 a.m. I would not check their blood for calcium levels before that, because you will see slightly elevated calcium levels than normal. Now, both Forteo and abaloparatide are contraindicated in patients who have metastatic cancers. That's the reason I was telling patients, if you have cancer and you know what cancer it is, please talk to your doctor who is treating you for osteoporosis so that they avoid giving you these medications. Now, it's not given in certain kidney disease, or if the kidney functions are below a certain range, and also in any bone cancers or Paget's disease. Now, abaloparatide is not studied in fracture healing or steroid-induced osteoporosis. Teriparatide actually has shown some promising results in steroid-induced osteoporosis patients. Now, there is another drug which was new in the market, is very, very popular nowadays. It's called Evenity or Romosozumab. It's a monoclonal antibody, comes as a 210 milligram shot. We give it as 2 shots, comes at 105 milligram, 2 shots, because of the sheer volume of the shot. They have been separated into 2 shots, and they're given once a month for 12 months. Generally, in infusion center, it's not given by the patients by themselves, because we generally monitor the patient for at least 15-20 minutes to make sure there's no adverse reactions with this medication. It is approved for postmenopausal women or women who've had increased fracture risk, or who've had a recent fracture, or anybody who has increased risk of falls. So, and steroid-induced osteoporosis. Now, it has not been approved for men, has not been studied for men. So we generally do not give it for men. However, it's a very good drug, helps build the bone through its osteoblastic bone formation. Again, this is one and done. After 12 months of shot, I again transition these patients on either of these drugs, either Forteo, abaloparatide, or Evenity, back to either reclassed or Fosamax or Prolia. The reason being, I tell patients, the anabolic agents are building your bone. So we want to build your bone as strong as they can and then freeze it in time. So we are freezing it by giving you the anti-resorptive medications. So we are not losing any more bone. There are 2 types of bone metastasis. There's osteolytic and osteoblastic. Some tumors, they cause the bone to get thin or break down and lose calcium. And these are seen in multiple cancers like breast, lung cancer, thyroid cancers that spread to your bone, kidney, prostate, and multiple myeloma. Now, there are certain cancers that actually make your bone harder or increase the bone turnover. That is osteoblastic cancers and making those bones thick and inflexible. Mostly prostate cancer patients and certain breast cancer patients. Now, bone metastasis can cause bone to fracture because they are making your bone thin. It can cause pain, and certain times it can also cause life-threatening electrolyte imbalance by increasing your calcium levels to very extremely high levels. This is life-threatening. Generally, we send them to the hospital with calcium about 13, 12.5, 13, because of the risk of arrhythmias where your heart is beating irregularly. So I generally tell patients, please make sure you're drinking plenty of water, hydrating, because excess calcium is excreted through your kidneys. Now, it can also cause bone pain if it's an osteoblastic bone metastasis, and it can also cause weakness. Now, prevention. This is the most important thing to make sure that you are not entering osteoporosis sooner. Now, the first question that patients ask me is, how much of calcium do I take? I tell them a well-balanced diet is the first treatment, or nutrition is the first treatment for bone building. So most of our milk is fortified. I tell them a rule of 300. So if you're drinking milk, a glass of milk, which is 8 ounces, you're getting 300 milligram of calcium. Cheese, a serving of cheese, 300 milligram. So in a normal person between age 19 and 50, we would suggest 1,000 milligram a day of calcium intake. Somebody above 50, 1,200 milligram per day. Now, if you're not getting enough calcium supplements through your diet, good source of calcium, I tell them, is dairy products, dark green leafy vegetables, broccoli, canned salmon, sardines, calcium fortified food. Certain juices also have calcium in them. If you're not getting these, then my suggestion would be either take over-the-counter calcium carbonate or calcium citrate. Now, the next question patients ask me is, which is better, calcium carbonate or calcium citrate? Both are good. Calcium carbonate has decreased absorption if you are on a acid reflux medication like omeprazole or ranitidine, because it needs a acid environment. So in those patients, I tell them calcium citrate is a better option because it is absorbed easily, and calcium citrate can be taken at any time. Calcium carbonate, ideally, I tell patients to take it with food. Now, achieving your goal. I always tell patients, please stay active. Exercise is the most important thing to build your bones. Bone strengthening exercises. If you have osteoporosis, please don't go to the gym and start doing these. I would suggest talking to a trainer or somebody who knows about osteoporosis, because there is high risk of fracture. I have seen more fracture risk in osteopenia patients than osteoporosis, because in osteopenia, they think the bone is strong, but and they take risks. And so there's higher fracture in osteopenia versus osteoporosis. And also the sheer volume of patients in osteopenia. We have almost 44 million patients in osteopenia compared to 10 million in osteoporosis. So I tell patients at least 30 minutes of bone strengthening exercises a day to keep your bone strong. Anything to avoid fall. So yoga to improve your balance, or Tai Chi to improve your balance and prevent falls. Vitamin D has been studied to prevent falls. Please avoid smoking. Smoking increases bone turnover and makes your bone osteoporotic. Alcohol, not more than 2 servings a day. Too much means more than 2 servings a day can worsen your bone density. Exercise helps basically improve your overall physical ability, helps to improve your self-esteem. You feel better after an exercise, lower the risk of anxiety and depression. You feel less nauseous, less fatigue, better balance, decrease falls, and decrease broken bones. Studies have shown that actually exercise with bone strengthening exercises, actually they increase the osteoblast. So it helps build the bone and make the bone stronger. And also helps your weight. So I would say exercise is the best thing. And as Katie said, we are having, I think, next month or the online virtual program, and I would suggest everybody to join in and go from there. Now, other tips, as I said, please avoid smoking. It actually makes your bone more weak. Avoid drinking too much of alcohol, because there are two things. One, it decreases the bone density. Second is falls, increased risk of falls. Bone mineral density test, please talk to your doctor and how often you need to get this tested. Generally, we do it every 2 years. And if you're on treatment, we do it every 2 years or yearly based on to see how it is improving or if there is any decline in your bone density. I'm now open for questions.
Thank you so much, Dr. Avdhani. That was a great presentation. We have a lot of questions that have come in from the participants, but I'll start with a general question. So someone had asked, what type of doctor should be treating osteoporosis or osteopenia? Sometimes it'll be like a family medicine doctor or a gynecologist, or even our teams as oncologists. Like when are you seeing other sort of physicians referring to you specifically for osteoporosis treatment?
So I would say it starts with your primary care. The primary care can start bone density and start you on a medication. But if there are certain secondary problems where you cannot be on this medication, I always tell them, please refer them to either endocrinology, and some of the rheumatology doctors are also taking care of osteoporosis. Oncology, I know you guys generally, when you treat breast cancer patients, you get a baseline bone density and start them on Prolia, which is an excellent thing because you're trying to prevent future fractures. And after a few years, if you feel that the bone density is not improving, I always welcome a referral, and it's always a two-way. So we can closely help patient improve their bone while they're being treated with cancer.
Okay, great. And someone had mentioned something about like hypothyroidism, and certainly thyroid dysfunction can sort of weaken the bones, especially if some people have sort of overactive thyroid. Do you have sort of a different goal in TSH levels if someone has sort of hypothyroidism and sort of issues with their bone health as well?
Yes, so this is a very common question most of my thyroid patients ask. Some patients want to keep their thyroid level, the TSH, as low as possible. Low means hyper. That means you are taking more thyroid hormone. Now, thyroid hormone is the metabolism of the body. So when you're taking too much, you're increasing your metabolism. In turn, you're also increasing the bone turnover, pushing you at a risk of osteoporosis. So I tell them, I generally keep patients in the normal range, a TSH of 0.5 to 4.5. Any TSH below 0.5, 0.3, 0.2, or even less than 0.1 puts them at an increased risk of osteoporosis. Now, I do have certain patients who have thyroid cancer, and we generally keep their TSH at a lower range, between 0.1 and above, but never below 0.1. Very few patients, we keep them in the lower range, but we always keep an eye and we always check their bone density. So to answer your questions, normal thyroid range is what we are aiming for.
Okay, great. And just going back to sort of the vitamin D supplementation to help with bone health, is there any sort of increased amount that you would recommend for people that have gotten sort of cancer treatments in the past? I know you mentioned 1,000 units and things like that.
Mm-hmm.
Does that level sort of change depending on their treatment history?
So the guidelines for normal people says that you need about 600 international units of vitamin D, which is around 15 micrograms of vitamin D a day. And anybody above age 75 needs up to 800 international units. Now, in patients, we always check a vitamin D level whenever we treat them with any kind of osteoporotic treatment, because vitamin D, I tell patients, vitamin D is like the magnet that attracts calcium. So without vitamin D, whatever calcium you're eating, you're just pooping it out. or you're peeing it out. So we want to keep the vitamin D in normal range. So ideally between 30 and above, but the best is 50 and above. If it is low, less than 30, I generally ask patients to take either 1,000 or 2,000 international units daily, and I check their vitamin D in 3 months. And some patients who have malabsorption, that is, who had surgery, I tell them to take it for the rest of their life. Most of my patients are on vitamin D, at least 1,000 international unit a day. Now, the question I get asked is which vitamin D? Is it the ergocalciferol or cholecalciferol? There are two kinds. Ergocalciferol is a plant-based vitamin D. Cholecalciferol is a animal-based vitamin D. Both are good. Both are potent, and either is fine. And most of them are over the counter. You can just go buy 1,000. Please don't take higher vitamin D because there's risk of hypervitaminosis causing elevated calcium, and you go in the opposite direction. So a normal level, I would say 1,000 international units up to 2,000.
Great, great. And talking about the diet, do you find that, like, do you have a recommended, is someone sort of trying to increase their vitamin D and calcium intake, how much sort of glasses of milk should they drink in a day?
So as I told, I follow the rule of 300. So a serving of milk will give you 300 milligram of calcium. So one serving, a normal person between age of 18 and 50 needs up to 1,000 milligram of calcium a day. So I would say patients, serving of milk, you're getting 300. If you're eating a serving of cheese, you're getting another 300. And then if you're getting a glass of, because most of the foods are now fortified with calcium, if you're not getting enough in some vegan or vegetarian diet, I would tell them, hey, go ahead and start taking calcium carbonate or calcium citrate, 1,000 milligram or 600 milligram a day to add to the food or the diet intake that you're getting.
Great, great. Someone had asked about, if you already have like sort of established osteoporosis, someone had asked if it could be reversed once diagnosed, and how long does it typically take for someone that has osteoporosis to notice some improvement in their bone strength?
So unfortunately, osteoporosis is a lifelong condition. And yes, we can bring the bone density from osteoporosis to osteopenia, which is low bone mass. But there is no complete reversal. We always monitor this patient for the rest of their life. They always need to be on calcium, vitamin D to keep their bone strong. And after, as I said, somebody on bisphosphonate, Fosamax, or reclassed, we give them for 2 years, get a bone density to see if it improved. Give them another 2 years and make sure it improved further. Once I reach a goal of osteopenia with a low fracture risk, I generally give them a drug holiday for 2 years. The same does not hold good with Prolia because Prolia can worsen the bone density from when they started with. So I generally transition them back to Fosamax and give them a year to year and a half of treatment and then give them a drug holiday. Even after the drug holiday, we generally monitor them with bone density closely every 2 years to make sure they're not losing or they're not going back to osteoporosis.
Great, great. Have you seen in your experience like cortisone shots? Because a lot of people, besides sort of decreased bone density, people have a lot of degenerative or sort of arthritis changes. Have you noticed any sort of issues with cortisone shots for arthritis degrading sort of the bone health?
So cortisone is again steroid, and the cortisone shots, yes, if taken over long term, any steroid for that matter is increasing your bone turnover. And if you're taking cortisone shots for a long time, yes, you are at an increased risk of osteoporosis.
Okay. I personally thought it was interesting that like the use of heparin and sort of certain anticoagulants can cause sort of decreased bone density. And so, because I honestly, I'm considering, do I need to screen, patients with the bone density scan if they're on long-term anticoagulation? Like, have you noticed sort of patients on heparin products sort of indefinitely if they need sort of more frequent screening or earlier screening?
So the only low bone density seen with heparin is the unfractionated heparin, so
Okay,
not with the fractionated heparin.
I
So
see.
I would not suggest screening if they're on Lovenox or any of those shots. But somebody who's on heparin for a long time that is unfractionated, yes, there is a risk.
Okay, great, great. And someone had asked, what are the side effects? I know you had mentioned some of them already, but what are, besides, the osteonecrosis of the jaw and things, can you go over again and sort of some of the side effects of Xgeva to help, that are often used to combat sort of bone metastases?
So the bisphosphonates sometimes are given monthly, I believe, in oncology world with
Yeah.
bone metastasis. And that actually, because the way the bisphosphonates act is it basically is trying to stop the osteoclastic bone resorption. So you're having the bone turnover has been delayed, and you have a mix of dead and new bone in the bone. So the bone is when you're giving a person more IV medication or close or more often, either you're giving Prolia every month or reclast every month, there's an increased risk of osteonecrosis of jaw. So you can see the jaw bone in these patients and they're necrosed. And generally I tell them, hey, please go to the dental doctor. Then sometimes dentists themselves will tell the patient that you have osteonecrosis of jaw. Please talk to your doctor to switch them from either denosumab, Prolia, or bisphosphonates to something else. Unfortunately, that something else is we don't have much options. So we always tell them, please get it treated, magic mouthwash. Prevention better is always good dental hygiene is the first thing. Or I tell patients, before you get your next shot of Prolia or reclast, if you have any dental procedures done, please go to your doctor, get them done before getting the injections.
Great, great. Kind of jumping back to like the DEXA scans and things, how exactly is the FRAX score calculated?
So the DEXA scan is basically testing the how good the mineral density of your bone is. Most of the time, it's checking the cortical bone. And FRAX score is an algorithm, is basically checking your age, your race, ethnicity, if you have been on corticosteroid in the past, if you have had fractures in the past, if you have history of rheumatoid arthritis, and then secondary causes fractures. So it's a they put in all these numbers and the computer will calculate the risk of fracture. So generally we tell patients if you have low bone density and the FRAX score says your total fracture is about 20%, that is high FRAX score. Or if the hip fracture is about 3%, that puts you at high risk of fracture. So that is high FRAX score. Anything below 20 as a total or anything below 3% on hip is a low FRAX score.
Great, great. When would you use one of those anabolic agents sort of first line for osteoporosis? Personally, I don't use that very often, mostly the bisphosphonates or Prolia, but when would you use that sort of upfront, like as a first treatment for osteoporosis?
So, patients who've had a bone density and a T score of less than negative 3.0, that is my first drug to go to because the other drugs, the anti-resorptive drugs, take time to build the bone. Anabolics are pretty fast. So, that's the first drug I go to. And any patient who had a fracture and we found their bone density is low, I first start the anabolic agents, either teriparatide, Forteo, abaloparatide, or the Evenity. And any patient who has had increased fall risk, I first start Evenity on these patients. Studies have shown that starting anabolic agents before starting anti-resorptive agents actually help build bone faster than the other way around.
Okay, great. How about women that are interested in pregnancy? Because I believe that some of the bisphosphonates can sort of cross the placenta. And so how about these like anabolic agents?
So generally, we don't give patients bisphosphonates. However, I've had when during training, I had a patient who had breast cancer and was pregnant. To bring her calcium levels, her calcium was through the roof. To bring her calcium level down, we had to give her bisphosphonate. with the caveat that it can cause congenital malformations in the baby. Generally, I don't advocate it. That is coming to a good point. Now, pregnant females, generally after delivery, they want to breastfeed. Now, from the time you're pregnant until you stop breastfeeding, you are not making enough estrogen. Now, when you're not making enough estrogen, your bones are getting weaker. So there are certain women who love to feed longer than 1 year. Remind you, the bone density is going down. I've had pregnant females, or actually female who just delivered with a fracture. So it is very common to see fracture or low bone density in women who are pregnant or who are breastfeeding for more than a year.
Okay, very interesting. And someone had sort of asked, kind of jumping back to a little change of topic here, but someone had asked personally, they have sort of high cholesterol levels and they've been told to cut down the dairy. So in those kind of situations where they might not be able to get as much sort of dairy products like the cheese or milk, what are other kind of food options to help increase the uptake for calcium, vitamin D?
So they can always do 1%, 2% milk if that is not allowed, because I know the lower the percentage, the lower the fat content is. But if they are not able to do that, calcium supplements or even green leafy vegetables or certain foods that have high calcium, or even fortified foods. A lot of foods in right now in our grocery stores have been fortified with calcium, vitamin D. The best option for them is take calcium supplements.
Okay, great. And I also think it's interesting that tamoxifen in premenopausal women can decrease the bone density, but it increases it can help sort of increase bone density in postmenopausal women. Do we know sort of exactly why the mechanism for why it decreases bone density in premenopausal women, since it has like a, partial agonist, or kind of helps stimulate bones in general? And so just wondering sort of why that is in.
So they have not done research into that, but they found that because of the selective nature of estrogen, because it's only done in pregnant or breast cancer patients. The research what we have is, so they found that the tamoxifen way it works is basically works better estrogen stimulator on bone or bone related osteoblasts than on breast. So it decreases the amount of estrogen in the breast and in the uterus. So basically, it's not the blood estrogen level, it's the receptors that it is targeting.
Okay, great. And someone had asked, should women be taking hormone replacement therapy, bioidenticals, to help with their bone health?
So that's a very good question. So menopausal women, the hormone replacement therapy has very good they found that it actually decreases benefits. It decreases cardiovascular events. So postmenopausal women is at higher risk of heart disease, stroke, heart attack after menopause because of decrease in estrogen, which causes problems in their cholesterol panel. So hormone replacement therapy for up to 10 years is generally recommended. Beyond 10 years, I say from 50 to 60, beyond 10 years, there's risk of breast cancer. I always advocate for a hormone replacement therapy in women. However, if they have a strong family history of breast cancer in their immediate family or early history of breast cancer, I would not suggest it as a drug of choice. Now, natural hormone replacement therapy, I have no studies on that, but if it is natural, I'm not stopping them from taking anything natural. They can go ahead and take that.
Great. Yeah, that's a very interesting question. One kind of final question was that someone, I think it sounds like they might have vitamin D deficiency, but they're taking 50,000 units of the vitamin D ergocalciferol, which is a lot, a higher dose than, the 1,000 international units. Should they be taking calcium along with it to help with absorption?
So I also put patients on the 50,000 ergocalciferol or cholecalciferol once a week for up to 3 months, 12 weeks. And I always tell patients after 12 weeks, please transition to either 1,000 international units of vitamin D or a 2,000 international unit vitamin D. Now, the patients that I put them on 50,000 is where their vitamin D levels are extremely low, like in single digits, 6, 10, 12, 20. But anybody with a vitamin D of 25, 26, I just put them on a regular 1,000 or 2,000 international units. Now, these patients don't have to take a calcium along with that, because the vitamin D, once we are repleting it, it's going to absorb the calcium, but make sure you're eating a well-balanced diet. Now, you take calcium if your blood calcium level is low, then yes, go ahead and take calcium, but otherwise, eating a balanced diet is good enough along with your 50,000 for 3 months.
Great. Thank you so much, Dr. Avdhani. This was very helpful, and the questions were great from all the participants. I'm going to throw it back out to Katie here.
Thank you, Dr. Avdhani and Dr. Chang. Thank you, everybody, for participating. As Dr. Chang said, you guys had so many wonderful questions, so it's so great to have an involved discussion about this. If you'd like to reach out to Dr. Avdhani, you can do so. I think we had our website up a second ago, but it's with Northside Hospital Diagnostic Clinic. And if you want to connect more with Dr. Chang and her team, she's with the Suburban Hematology Oncology Associates, and I think that's GwinnettCancerCare.com. If you know anybody who was unable to make today's live presentation, please let them know that we're going to have the recording available. We're going to email it to everybody who registered, and it will also be available on our website. Again, that's cscatlanta.org. I'm going to do one last plug for our bone health series, exercise series coming up next month. That's offered both virtually and in person. So if you'd like to connect with that, I'll put that link again in the program chat box. Thank you, Dr. Avdhani and Dr. Chang, for being so generous with your time and expertise in today's program. And thank you all for joining us. We hope to see everyone soon. Take care.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.